Good afternoon, everybody. Can you hear me? I'm using a new pair of headsets today, so.
Looking good, Thomas.
Awesome, thanks. We'll wait one more minute to let everybody trickle in, and then we'll get going. Tom, I can't tell if that's a good background, like a positive background, or a foreboding background.
I think it's foreboding.
Oh no.
April 10th, July 19th, October 13th. It's not good. 3 peaks. The question is the third peak, how high?
Oh. This ties into our deep dive in terms of the more mental health social science of the fatigue. So I guess we'll get going, and as people come in, we'll say hi and continue our discussion. So good afternoon, everybody. Let me share my screen. Oh. Levi, do you think, or Rukia, can you give me access to share the screen? I forgot to, oh wait. There's a way I can.
Yeah, it says I don't have access either.
Okay. I did it once. I just can't remember how to do it again. Sorry, team.
I think it's under share screen, no?
Yeah, but I don't have access. There's a way for me to typically hop on. Levi, can you Slack Bobby really quickly, please? Apologies, everybody. Normally, we have this sorted out.
We're picking up on some good verbs. To be slacked.
Yeah. General video. Nope. I know it's possible because I did it once, and then I can't figure out how to do it. I'll do it again. Oh, here we go. Clean host. Here we go. Got it. Okay. Yeah, can everybody see the presentation? Okay, so thank you for bearing with me, everybody. Good afternoon. Welcome to the 22 October HiPAM community meeting. So we're going to go through our update concerning, yet again, I'm sure this is not a surprise to everybody who's following any type of news, doesn't matter. We are continuing to see an increase nationally. 52,350 was the 7-day case average last week, Thursday. And unfortunately, as you can see, both numerically and graphically, that continues to grow up, I went state by state on CDC's website. Currently, there are 42 states trending up, some slower than others, 6 trending down and 2 kind of holding steady. So I know at one point earlier this week, we had about 48 states increasing. So that's good that it's not, that number of increasing states is slightly decreasing. But once again, as we move into late October, early November, for all the reasons we've discussed over the past couple of weeks in terms of reasons why we could see a third wave continue to increase, this is not, the evidence is there that we're not yet on the downward trend nationally. For the state, however, we are decreasing our, sorry, apologies. This is last week's 91 was our 7-day case average. 91 case count, 9.6 hospitalizations, 3.2 deaths. Cases are going down for a 7-day average by about 10, so that's really good news. Today was a little bump, but once again, we can't make any assumptions from a single day data point. Hospitalization slightly increasing, but nothing too concerning yet, and deaths slight decrease, so nothing we can take away too much from the changes from last week to this week, minus the case average slightly decreasing. Our 70 average went from 101 to 78. So once again, that's good that we're slowly trending down. Hopefully that trend will continue in the next few weeks. And if that's the case, then maybe we can start to let some of that that held breath let go in terms of maybe avoiding a third wave, knocking on wood. 70 average new deaths increased from 10 to 14, but once again, you're going to have a lot of fluctuation, especially with deaths, because in Hawaii, because our N is just so much smaller, which is a really good thing compared to other states. 78 new hospitalizations down. Once again, that's really good. And ICU current hospitalizations due to COVID is trending down again. One thing to note, one of the reasons why we decided not to put ventilators as one of our metrics is because, as some of our physicians on our call can attest, our treatment has improved, and we're learning that ventilators actually increases one's risk for lung failure if you put it on too soon. So that's why we don't track it, and that's actually not one of the limiting factors that we thought it used to be early on in the response. Percent positivity, 3.6, but once again, it's still trending down for the most part for the state. I know St. County, Oahu, I was driving, is 2.7 today, but once again, something to keep an eye on as you move forward. Testing turnaround, slight dip from last week. Nothing too concerning yet, but this is a really important metric to look at as we start to see more and more visitors come in. I think from when we opened till yesterday, we had about 50,000 total from what the news was reporting. So that's quite a large number of both tourists and returning residents to keep an eye on, and might tax our lab capacity and testing turnaround. So I spoke from a state perspective, 42 states increasing. Texas, Arizona, and California now are all increasing. Texas, Arizona, pretty consistently now. It's not a blip, it's consistent. California, we're still, from what we're seeing from the past 2 to 3 weeks, this could just be fluctuation from week to week. Maybe hopefully that's what we're seeing, but once again, it's still too early to tell for California. Moving on to our science highlights. These two articles were actually found and sent to me from Itzvan and Marguerite, both who are able to make it today, or hopefully they can hop on. But the excess deaths, that's nothing that, if you're paying attention to, should surprise us. There's just a lot of reasons why we're seeing an increase in excess deaths due to COVID. Not directly due to COVID, but associated with COVID in terms of, not going to the hospitals, not seeking healthcare, and then the mental health aspect causing people to turn to alcohol and drug dependency. And then obviously the nursing home deaths, and then people with Alzheimer's and diabetes still not getting access to healthcare. This one was actually really interesting because there's a couple other articles related to this topic of ventilation, but also I believe United and Department of Defense put out a study today or yesterday where they're saying, oh, the risk is really low traveling for aerosolized in an airplane. But Itzvan sent this article, and basically it's updating the guidance. Early in the response, it was 6 feet. You're good. It's mainly droplet transmission, very, very limited aerosolized. But what we're seeing now is it's really not that simple. There's more nuance to the size of the droplets and where the people are. And what the conclusion of this article is saying that if you are inside and it's not well ventilated, that's actually, even if you're wearing a mask, you still have a pretty good risk of contracting COVID. So once again, as we open up our restaurants, it's important to note how these restaurants are ventilating themselves. If they just, I've noticed a bunch of restaurants open up the doors, not have the AC on and not have fans. So once again, this open air, while you know, the misconception that, oh, they have the open air, that's good, but if they're not ventilating within the facility, that's probably not good. So as the science continues to improve and updates, that's also something that the policymakers should also communicate to the businesses, because if not, then we could see an increase in cases as well. So before we go to the deeper dive, I wanted to pause slightly to discuss any of these two topics, because I think they're really relevant for Hawaii, especially as we are now, or for at least Oahu, as we are now in tier 2. Restaurants are opening up more. I believe, are they at 50% capacity? There's too many things to keep track of depending on what business you are. But if they are at 50% capacity, that is something to keep an eye on. And also if people go back to their physical workspace. But any thoughts on either the excess deaths topic, which we will hopefully explore later on in depth in the next couple of weeks, or the ventilation issue?
I can probably go on quite a spiel about the ventilation issue, since I'm a pulmonologist. But
oh yes, please.
Don't know if there's any specific. I mean, the quick key on it is, you know, in healthcare, there's a verbiage issue. So you talk about aerosolization. In medicine, that's typically a respiratory droplet that's less than 5 microns, because that's the size of a droplet that will reach your very, very distal airways. But in occupational health, they actually use a different verbiage for it. Aerosolization to them is any kind of infection that can be spread through ventilation. So it's not a droplet size. So we do know that there's all these great videos. I have a whole presentation on this. There's these great videos you can probably Google of this flash microscopy of somebody sneezing, and then you see their little cloud of spit, you know, past 20 feet. So, you know, that's why we advocate about, you know, mask wearing. You know, sure, cloth masks, they're not going to filter out those 5 micron particle sizes, but it's going to help with ballistic droplets. Ballistic droplets are kind of those large respiratory droplets. And then there's this advocate about face shields, because that'll, you know, cover your eyes. There's a whole New England Journal about it's not an aerosolized infection, kind of like measles and whatnot, but it's a respiratory droplet thing. So, you know, what are all the different measures? Again, there's a whole bunch behind this. I think the general thought is, yes, it does get spread through respiratory droplets, but when the CDC says respiratory droplets and not aerosol, what they mean by aerosol is not that medical term, that fine particle size. So again, I think there is a lot of confusion regarding this. There are clear guidelines out there. ASHRAE, the American Society of Heating, Refrigeration, Air Conditioned Engineers, they have guidance out there. Their guidance, though, is impractical. They talk about, you know, I have my SMASH acronym for, you know, reducing your risk for COVID. S is, you know, stay away or stay home if you're sick. M is mask up. A is air, you know, ventilation. And if you can't ventilate well, filtration, because HEPA filtration is also a possibility in those that are in closed areas. S is, you know, stay away from others, that physical distancing, and H is hand washing. But yeah, the A, there's a whole bunch of information regarding it. A lot of confusion is probably because of that mixture in terminology between medicine, aerosolization, 5 microns, versus occupational health, which is respiratory droplets that can spread through the air. But
no, that's super helpful, Dr. Wu. You probably should have told me you had a slide deck or a presentation, because now I'm going to ask you if you can give a brief summary in the next, you know, in one of our future meetings, because this is important. Even for myself, who follows this on a daily basis, I thought I had the aerosolized and droplets down pretty well, but it sounds like there's even more nuance, and I wasn't aware of the communication, the lack of communication, or the discord of communication between, you know, pulmonologists and the clinicians versus public health officials. So I'll reach out to you and see if you wouldn't mind giving a brief 10-minute presentation in one of our future future talks, but that's super interesting. Thanks for sharing. Any other comments on either this topic or the excess deaths, which we will talk about in our deep dive in a bit? Or is everybody just kind of COVID fatigue? We want Halloween, et cetera, et cetera. So on that note, in terms of COVID fatigue, that's, you know, I know HiPAM is associated with, first and foremost, with the modeling and the math, which we still are. But as we learn more and more, I think it's important, and as the regular members have seen, we're increasing our scope in terms of all science and logistics for COVID. And I think what's been growing more and more, you know, in terms of prevalence and relevance in the past month or so, is this issue of COVID fatigue, and really, what is it? So there's a really good New York Times article. As once again, we're in our third surge, depending on where we are. There's a lot more focus now on pandemic fatigue, and you know, in the beginning, this was already a red flag for our clinicians, our mental health experts, who were spot on in terms of identifying it early on. But obviously, in our society, you know, we wait till the last minute to address anything. Unfortunately, public health and prevention is not yet a priority. Hopefully it's increasing. So once again, you know, in the spring, this was really catching quote, in the spring, it was fear and sense of we're in it together. Now things are different. You know, the fear that people used to have, it's just, we're tired. I want to go back to going to the restaurants, going to the theaters, eating popcorn, not even worrying about it. And right, you know, we've said so many times in our HiPAM meetings, it's always been a marathon. And even myself personally, you know, there's times when I just get tired as well. So, you know, today where we talk, what is COVID fatigue? What are the impacts? And can we guard against it? So keep it simple. It's really, it's just being tired of having to change behaviors due to COVID. And that's linked to the desire to return to whatever your normal life was, whatever your normal activities were. For example, Halloween, Thanksgiving, Christmas. So Halloween, there's drive-through Halloween now where you're staying in the car in like parking lots at Pearl City or Ala Moana. So once again, that's completely different. Thanksgiving, the guidance is to keep it small, keep it to your tight bubbles, but we'll see, you know, Hawaii is notorious for these large gatherings in carports and family houses. So we're yet to see what that impact is. And then obviously Christmas, and then travel. You know, even though a lot of our college students decided to stay home, you still have a bunch of college age students who are one of our highest risk demographics for transmission, for asymptomatic transmission. So we're going to see the impact pretty soon. So there's a term that when I was looking through and trying to understand more about COVID fatigue, Coronaphobia, and I thought that was an interesting term. And in this article, it's still a relatively new term, obviously, as COVID is a new virus that we're trying to grapple with, but it's really growing in its usage in the psychological community, where it's linked with increased use of prescription drugs to cope with stress and anxiety as the demand for anti-anxiety, and then it's supported by the increase of demand for anti-anxiety medications, up to 34% from mid-February to mid-March just this year, right? And that's obviously concerning for multiple reasons. And then that's linked to COVID fatigue syndrome in terms of, yes, people are getting tired of wearing the mask, but we're also seeing more and more people resigning themselves to the fact that if they have symptoms related to COVID, they're not seeking care immediately. They're waiting until it gets to a point where it's pretty severe, and then they'll seek care. And that's really concerning, one, because that reduces their risk of, or reduces their probability of survival, but then that increases their probability of being in the ICU and utilizing that type of facility for care. So once again, we have Coronaphobia linked to prescription drug usage, just COVID fatigue syndrome, people just resigning themselves to the fact that they'll probably get COVID and they might not, they'll wait to seek medical care. So what does this mean for Hawaii? Well, if you remember what I showed you from the trends, we're doing well with ICU utilization, hospital utilization for now, right? But that's, you know, that's only one part of measuring impact. It doesn't show how many people are seeking mental health. Though we are trying to track that, and DOH is trying to track that. We know that all demographics are impacted for the most part, regardless of race, gender, ethnicity, social economic status. While it is apparent that those that are on the adverse side are going to be more adversely affected. So I want to end. I want to leave a bunch of time to discuss this. I think there's a lot of avenues to take this this particular topic. But in terms of global health, when I taught global health, a lot of these topics were very depressing, just because that's the nature of it. So I always like to end it with a positive note in terms of there are still things we can do to control our personal relationship with what's going on, in terms of if you find things like hobbies or staying outside, working out, healthy diets, that does reduce the impact, the adverse impacts of COVID fatigue and all the mental health impacts due to COVID. So with that, I'm going to just say that now, next week, I believe Tom and Janet will be presenting on the topic of schools reopening. I was a little ahead of myself last week, but I believe we have the timeline set for next week. But I'm going to go ahead and just open it up to everybody here. And sorry, I didn't get a chance to look at the chat. I'm taking a quick glance, but I think this topic of COVID fatigue is really relevant, because you know, it really, for Hawaii, we're at a point where we can either continue to trend down or hold steady, or really go up, and that's really tied to our behaviors and whether or not we continue to stay vigilant. So yeah, I'm just going to open it up to everybody, because I think that this is such a relevant topic, and there's no science per se involved in this particular topic.
This is Yosh. I had heard in one of the talks that we had here at Queen's is that anecdotally, I think the people coming in for hospitalizations actually are coming in quicker compared to what they used to. I think there was a lot of fear before, like especially early in the summer, that people weren't coming in, and now that people are like, okay, I feel sick, I have COVID, they're willing to come to the hospital earlier, and that's leading to better treatments and shorter length of stays. So just a little positive note on that side.
No, that's really good, Yosh. That's that is positive. That's uplifting, because it's hard to come by good news related to COVID these days. Besides the remdesivir being, I think it's been proven to have strong efficacy, and I think there's a press conference today about announcing the vaccine logistics, which Brian, I know you're tied into. But any other comments on COVID fatigue before we kind of dive somewhere else?
I guess I would just comment that, since you asked, that I think it's tied to some of the things you talked about, like increased use of anti-anxiety meds and stuff, are tied to all of the social, emotional, behavioral health things that we're seeing. And in addition to the things that you mentioned, I was just talking to Eddie Mercero in the Behavioral Health Administration, and there's clearly nationwide and locally an increase in things like domestic violence calls, child welfare calls, depression, suicidality, all of those things. So it's a, you know, all of those things are connected. And I think that those things are also connected not just to the disease, but to the economic and community impacts of disease. So I recently had an exchange with the lieutenant governor about, you know, people are depressed because they're unemployed and their livelihood is gone or going, or they have unstable housing, and we have to stimulate the economy in order to address those mental health issues. But I don't think we can really tease out how much of the mental and emotional health issues are from those economic impacts versus from things like fear or fatigue from the social impacts and the disease itself. It's multifactorial and they're all interrelated. So yeah, and I'm reminded of a news commentator who I heard actually a couple of months ago now say, you know, we're tired of COVID, but it's not tired of us. And, you know, we sort of don't have a choice. So anyway, thanks.
No, thank you, Dr. Berman. That was a really good point in terms of it's all multifactorial, but it's all interrelated. And you know, I was working with Bobby trying to look at some data, national data, and so many of the questions that we have really good information and survey information that are being collected at a national level, at a state level. But what we realized, and this is to tie back to the data nature of HiPAM, is it's so hard to tease these out because so many of these outcomes and so many of these variables, whether or not they're outcome variables or predictor variables like socioeconomic status, access to healthcare, access to food, they're so strongly correlated. And for the non-data folk, that just means they're so similar that even if you were to try to figure out associations between them, that really doesn't tell us much because intuitively we already know that those relationships exist. So what can we do with some of this good survey information for the analysis and apply and share it with our policymakers? So it could just be that we're just describing what we're seeing to the policymakers, so then they just have, it's not anecdotal and they see a clear relationship, even though it's common sense, but at least they can take this and be more informed when they craft their policies to say, hey, this is what the science, this is what the social science is saying to support in stimulating the economy or providing increased services for mental health, et cetera. So that's a really good point.
Actually, I just left a Zoom with some of my students, 300 level stat class, where I was helping them with two-way ANOVA with multiple factors and repeated measures. I'm like, oh, if we only had some COVID data we could work with here.
It's out there. Unfortunately, a lot of it's cross-sectional right now, which makes sense because we're not even a year into COVID. So we're not, it's the only longitudinal data we're going to have is on a monthly basis, and you know, it's really hard to get quality data because the questions keep on changing, the methodology keeps on changing. So
someday,
hopefully soon, hopefully before COVID ends and it's all a moot point from an academic and research standpoint. So
wow, I mean, this may not be our last rodeo with epidemics coming up.
That is correct. I unfortunately I agree with that statement. I love that statement. Well, I think the quote that Dr. Berman used, where we're tired of COVID, but it's not tired of us. I think that should be a bumper sticker or that should go someplace because it's truth. And as much as we don't want to hear it, COVID doesn't have feelings. It doesn't have emotions. It just like our mathematicians who are often remind us, it's either exponential increase or exponential decay, and really we control whether it exponentially increases or exponentially decreases. And try as much as we can to communicate that message in a way that resonates. And I hope next week we can share a video that one of Monique's students put together. It looks really good, and I know some of our Hawaii Data Collaborative team has seen it. I think it will really resonate with not just this group, but with the large population of Hawaii, because it's I think it's a surfing dog or a pig, I can't remember. But it relates surfing with the increases in COVID, and if the wave gets too high, you can't surf because you're going to crash and you're going to eat it, right? So we want to keep the wave manageable so that you can keep surfing. So hopefully I can share that with the group next week. I just got to dig it up.
Could I add one thing?
Yeah, of course.
I'm curious what Dr. Wu thinks about this, but I also think of it as being like people with a chronic disease, somebody with asthma or somebody with diabetes, because people clearly experience fatigue with their chronic disease. And what they tend to do when they experience fatigue is stop their efforts to manage it. And then they see it get much worse. And then they're faced with the additional effort of bringing it back under control. And then they get back into maintenance and then they get fatigued again. So it's, I don't know, I'm increasingly thinking of it as, at least right until we have a vaccine, as kind of a chronic condition for all of us, and that we're likely to have those kinds of cycles also.
Yeah, I completely agree. I think I actually mentioned that in one of the HiPAM meetings super early on too. Exactly, I view it in that same way. But I mean, it is, you know, as Thomas was speaking, I was like, well, what is analogous to this in our world? And I was thinking, well, would World War II be something analogous to this? And then I thought, no, because even at those times, social interaction was possible. These are, I mean, it's just an unprecedented thing that we're going through, and you know, finding coping mechanisms is the key. And yeah, I have no enlightenment. Yeah.
Thomas?
Yes.
Hi.
Yes, sir. Hey, how are you doing, Jim?
Good, good. I've been, a recurring thought has come to me over the past few weeks, and I think it relates to this topic of fatigue. When Dr. Berriman mentioned that, and other people, that the common thread is, you know, we control this virus. Our behavior controls it. And I noticed that, you know, there's in the social media world, there's quite a disparity between people that are blaming travelers for all of the COVID woes versus people blaming the community for all the COVID woes. And obviously they're kind of banging heads a little bit. It seemed to be, you know, and the lieutenant governor and his other state and county spokespeople are really, and especially groups like COVID PAL, are their message seems to be, look, folks, you have to behave. Just the mayor this afternoon, the Honolulu mayor, just this afternoon, the community really has to, you know, we can get to tier 3 and 4 if you know, the problem with that is, or I think it's an oversimplification, because you know, I don't have the epidemiological basis for it, but just based on what Istvan relayed last week, the transmission of this and explosive clusters can be traced to a very small number of people. So if that's true, and to the degree it's true, you could have your, you know, 80, you know, like look at the mask numbers. If the mask numbers were really telling us how well we're doing at controlling this by our personal behavior, we would be probably pretty good shape. It says something like 80+%. But that's not the case. It's not, you know, go to Lanai. It's not the case. So even if the emphasis is on getting the community to behave well, and you know, I don't want to get too political here, but we know there's like 30 or 37% of the U.S. population. It's a little bit bonkers, and they do crazy stuff. And if that number is out there ignoring all the social good practices and spreading the virus, the community is not going to be, the majority of the community is not going to be able to have the desired impact, no matter what they do.
No, you're absolutely right. In terms of the mask compliance, and Monique has modeled out, and I've looked at some of her work and helped her out. So we hopefully next week she'll be able to join us and we can share some of the visual graphs in terms of really what we've seen be the most effective from a modeling standpoint from different scenarios is not just 100% contact tracing capacity, because that's a mythical number, because if we have exponential rise, no number of contact tracers will be able to keep up, right? So a sufficient number of contact tracers, but also a relatively high percentage of compliance. And that's where, from a modeling standpoint, we have seen the most success in terms of kind of keeping it steady where we are, right? A little under 100, maybe 60 to 80 to 90 on our 7-day moving average, but that's sustainable, right? But even then, that takes everybody or most everybody being on their best behavior and everything on the logistical side working, right? Our contact tracing, our testing, turnaround, staying at a good level that it's at. Our isolation quarantine facilities continue to increase in their capacity and the outreach, right? But all it takes is maybe going from 75, 80% compliance to 60% compliance. And once again, that's hard to measure, but we can kind of quantify that on a modeling standpoint, and then you start to see the increase again, right? So we're close to feeling comfortable with sharing our modeling. Once we do, I think that's maybe one of the benefits of having some science drive the messaging of, yes, everybody's tired of hearing wear a mask, right? We all get it, but now we can kind of show the differences of what percentage of the population, if they comply, the impact it can have on disease containment and the levels that we can have to successfully continue to go from tier 2, tier 1 to tier 2 to tier 3. And I agree that the messaging in terms of tourists versus returning residents, I think it's at this point we need to just say it's everybody's responsibility, because tourists can spread it, returning residents can spread it. It all depends on the interactions, and not trying to single out anyone, because then that's kind of where you create the divide. It's really everybody in this together or not at all. So I agree with a lot of your points, Jim. Before I forget, I appreciate your feedback, Jim. I wanted to just touch back briefly on Dr. Berryman and the chronic disease. I think, at this point, everybody understands the nature of chronic diseases in terms of diabetes, hypertension, and what it takes to manage that, regardless if you have it or not. And maybe that's another way where we can connect with the public, because it's a long-term thing. Things like insulin shots, or I'm just kind of brainstorming, but kind of relate these things that have been mainstream in the public with these very mainstream diseases, relating that to COVID, as analogies, once again, because just trying to break up the monotony of the constant wear a mask, wash your hands, etc. So
it might even, because not everybody has a chronic disease. I mean,
yeah.
As you say that, it makes me think about things that are other healthy behaviors that, as a public health person, I know everybody's tired of hearing too, healthy eating, exercise, getting enough sleep, all those kinds of things, but sort of how one incorporates at least some of the COVID safe behaviors in the body of other safe behaviors that we do on a daily basis to take care of ourselves, even though we may not like it, so with occasional lapses, as we all do in everything, but normalizing it a little bit. So I don't know if people are ready for that message, or if is right for that message. But yeah, so it's good to think about other ways of communicating.
Well,
Definitely.
where I was going with that observation was that, if the government says, public, you have to do all this stuff and we'll get out of this, the implication is that the government doesn't have to do anything. That's maybe oversimplification, but the real point I'm trying to get to is, if you look at some of the crazy behavior around COVID, unsafe, maybe not so much in Hawaii, although our large parties are probably analogous to some of the political rallies on the mainland, where there's just clearly people are not only kind of, forgetting about the safe practices. They're actively rebelling against the safe practices. When it gets to that point, or even before it gets to that point, if a small number of people is all it takes to ruin, the R naught or the RT, the transmissibility, and it's going to keep increasing or never go away, then I think at that point the government does have to step in and put in place regulations, and more importantly, as we know all too well here, they have to enforce them. And if it means over regulating, like keeping restaurants, indoor activities, church gatherings, bars, or keeping bars pretending to be restaurants closed, because a small number of people is going to keep us in this virus forever, then I think that's something. I don't know how the data supports a conclusion about that, other than trying to, as a direction you were going in, Thomas, to try to get the data to support the percentage of compliance we have to get to, and saying we're not there. And if we just don't get there, then government has to take a more active role. And I know, nobody wants to hear that, especially government. But I think it's to keep saying that if the public could only, just be a little more careful, and I think it ignores that small percentage that could keep us in this virus for a long time.
No, you're absolutely right. Sorry, go ahead, Isfan.
Yeah, I'm just saying that there is a couple of silver linings here. So it does look kind of bad that a few individuals can spark a cluster and they can ruin it. But first of all, actually those individuals self-eliminate themselves. So it's kind of, this is why, the initial, at least the model, the initial large R naughts can go much faster down than in the average SIR models, because the people who are displaying the craziest behavior actually will self-eliminate themselves and things get much better. Unfortunately, that's only true for the local community. It's not true for travelers. And of course, people who want to come to Hawaii to have a vacation in the mid of a COVID crisis probably are the people who are prone to more risky behavior. But in general, that's the trend. So that's one silver lining. The other one, and that can inform, the essentially public health policies, is that you can do a lot of things where you're targeting, and beyond just closing restaurants. For instance, you could actually produce very good ventilation. Like one new thing that I read is that you can produce ventilation. So if the government would say, okay, you have to close your churches, but you say you have to open all the windows, you have to put in big ventilators and so forth, that already will eliminate the transmission probability a lot. It's not that people will not get it. If there is somebody COVID, maybe people right next to that person will get it, but not the whole congregation. And that's a huge difference, because again, a few people in this situation. So you can actually target both individuals. I mean, there are people who are prone to this kind of super spreading structure. And basically you want to test those individuals. When you have a vaccine, you want to give the vaccine first to these guys. And you can target super spreading situations, which are churches, hospitals, old homes, prisons, military, and so forth. And you can target those places. And even doing a few small things like ventilation. Like ventilation is a huge thing. Like if you put in big ventilators, you can eliminate a huge fraction of even if people are not willing to wear masks. Like if you just told, people who want to have these indoor political rallies, the 37% or whatever you call it, if you just require them to have ventilators, you can save a lot of them. I mean, they are still, maybe they should be saved, even if they have their own, even if they would go into the problems themselves, I think we should try to save them.
No, I like your direction. It's fun, and I shared the article with the group that you slacked earlier this week in terms of the ventilation. You know, what we know now in terms of how the disease is spread is 100 times more than we knew in April, right? We know R naught, or the RT, is not the most important factor. You know, it is part of it, but it's not the most important. Probably the K, the dispersion factor in terms of super spreading events. The ventilation, we're learning more and more about the droplets. So in terms of, you know, to bring this, to summarize the great points from all of our participants, you know, Jim, in terms of, you know, the role government has to play, I think just communication in terms of, as the science improves and we know more and more, how then do we once again translate to policy so that the businesses can then increase their capacity to decrease risk of transmission via what it's fine, like what you said for the church example, you know, all these high risk areas, once again, if we can help them from a physical standpoint, reduce the risk of transmission, maybe they have a chance of coming back in a different capacity, with limited volume, but with increasing ventilation, all these other things that we now know can decrease the risk of transmission. That's a way where we don't have to just shut down or just say, basically tell the bars you're never going to open until COVID passes, right? Or gyms or these other high risk areas where now we're learning how to better mitigate some of the transmission factors. So, you know, but once again, it's not just telling the businesses to do it, but you know, it's a government trying to work together with the businesses, and whether or not it's regulating it or just suggesting it or providing guidelines, because the businesses themselves might not be up to the science, right? That's where I think that communication is key, and hopefully, you know, some of the takeaways from this discussion can make its way to COVID POW or other community organizations, and as HiPAM, we can work together with our community partners to take the science and kind of translate that to a way that's understandable to decision makers and the concerned public. Before we close out, I wanted to not end, but I wanted to share the video just to bring a smile to everybody. And also, this is a great example of student-driven messaging that should permeate through everybody. Can everybody hear the audio? No.
No, I don't.
Dang it. Then I unfortunately won't share because I'm not that tech savvy to be able to share the share. Actually, let's do this.
If you take off your headphones, it might work.
Yeah.
I mean, turning on your computer's speakers.
Were you not able to hear that still?
You can close caption it. We can do that one.
So can you guys hear me now? So I highly recommend watching that with the narration. It was and the lovely background music. I think the closed captions doesn't do it justice, but I think that really addresses some of the topics that we talked about in terms of, Jim, you brought up government and how much the government should interact or take charge, and some of the graphs that we saw modeled out different scenarios in terms of great government control but low compliance, and good compliance and not enough contact tracing, and then we found this happy medium. And then we translated to something that everybody in Hawaii can understand, which is surfing. And then instead of using people, I love the animals. And so hopefully, if you want to share this, please share this, because I think this is a great way that we can utilize the data, the math, the modeling in a way that communicates effective messaging and the main topics of what we're trying to get at, and how we can reduce it, and that it's everybody's responsibility, not just the government, not just the public. And then we can kind of ride that steady wave that we were talking about and kind of manage the volume in the ICUs and the hospitalizations until we get to a point where we have both cheap, effective treatments, vaccinations, and really good, fast, quick, and cheap testing, mass testing. So I think that really actually, that was better than I thought. I forgot some of the topics that the video covered. So that was a good summarization of some of our major things. And it brought a smile to my face. So hopefully it did to you. So that helped with the mental health aspect of COVID fatigue. But with that, we have a few minutes left. I'll open it, or I'll stop sharing. If there's any last minute alibis or comments before we close up for the week.
Thomas, to the extent that you're holding your cards very close to the vest, and as in terms of your interaction with the government, when you listen to what they say, they don't say, well, HiPAM, this regulation is based on guidance from HiPAM, or they don't say that. They don't tell you where they're getting the numbers from. And people, I know public trust is one of your goals. Well, there isn't any public trust, it's deteriorating. But to the extent, part of the problem I know is that you're reluctant to forecast much more than you've been doing, a couple of weeks and so you're not, you're maybe not in a good scientific position to make forecasts about the effects of opening up and bringing in travelers and doing all these big things. But to the extent that everybody who saw that video said, yeah, you're basing it on real data. So you can, I know they don't listen to you as much, the government doesn't listen to you as much as maybe you'd like. And maybe you think sometimes they, take the wrong action. I know that even Mayor Caldwell said or admitted to the fact that he ignored DOH's advice on his opening of the restaurants. So to the extent that a video like that, or data presented like that can give you some leverage in your arguments, I would exploit the heck out of it. Go for it.
For sure. Thanks for that, Jim. And we have worked with or started our discussions with COVID POW, and sent them the video, and hopefully we can continue to increase our relationships with public partners and maybe private partners as well to increase the bandwidth of HiPAM and the purpose of HiPAM, which is to use science, use data to increase awareness and to hopefully inform policymakers moving forward. So, reminder that HiPAM is still very nascent in where we are. We were only started in April, and I feel like everybody is trying to pave the track that we're currently running on. So progress, I totally get it, and it's a marathon, and not to beat this dead horse, but we are slowly making progress day by day. But I appreciate the constant feedback and the interactions from everybody here, from both the outside public and our core partners as well. It's going to be vital as we move forward to continue to get our messaging out. And we have 3 minutes left. I think everybody here knows each other except for, I just want to introduce Matthew Daniels. He was my platoon sergeant when we were a platoon leader, but now he's my NCOIC. So we're once again increasing the reach that we have, and once again, the more audiences, the more bubbles we can reach in terms of our messaging, the better we can be. And with that, I want to say, go ahead.
I do have about 16 years of infectious disease experience with the VSL 3 and whatnot in Walter Reed and Bethesda. So not just the NCOC.
Yeah, no, for sure. No, and that was before we worked together, and I apologize. Yeah, he's a great lab technician, but he's also a very talented artist. So Adrian, if we're looking for, and I totally forgot, my brain's been operating at less than 100%, but if we're looking to update our logo or some of our background images, Daniels is the guy to turn to. Any other last minute, or not, any other last comments before we let everybody go and start to crack open a cold one or go back to work? I'm sure Dr. Behrman's probably having to go back to work.
Yeah, so know, Jim, that we're all definitely trying to, we're talking story in the models, a bunch of people are doing it. So in the background, the stories are still happening, and most people are, looking up and to the left. But it's happening.
Sounds good. Well, thank you everybody for your participation. Please join us again next week. Looking forward to learning about schools and the impacts of school reopening. And I'm happy that I don't have to take the lead on that one. So it'll give me a chance to listen and to learn as always, but we will see you guys next week. Thank you everybody for tuning in.
Thank you.
Thanks, Thomas.
Thank you.